and what they're doing has become blurred. I think that we could rightfully say that our sense of purpose is unclear, and to a certain extent, the therapeutic values, if you like, of acute wards are maybe less clear. Perhaps they've been submerged under almost sort of a tidal wave of paperwork and risk assessments and CPA and all the rest of it. So that the things that actually turn us on, the things that actually make us feel like good quality nurses, the things that actually brought us into the job in the first place, are often the least visible bit of our job. And what by that I mean the things that actually put us into genuine, meaningful contact with patients. It's my observation that we perform a large number of tasks, all of which are secondary to the reason that patients come into hospital. The reason people come into hospital, for me, well, actually there's two for me. One is to get a more intensive level of input from skilled workers, and the second one is to maintain the safety, usually of the individual, but occasionally of those people around that individual. So safety and intensivity. Now, I think we often get the safety right, but the intensivity of input, I'm not sure we do. A few years ago, Mind, the mental health charity Mind, in their report Environmentally Unfriendly, argued that in the acute wards that they had surveyed, the vast majority of patients were actually getting less than 15 minutes of meaningful engagement on a daily basis from mental health workers. Now, if you add that up, let's leave the weekend to one side because people might stay in bed or have relatives or whatever else. If you say Monday to Friday, you're looking at an engagement period of 75 minutes. Now, if you were quite poorly and you'd been picked up by the intensive home treatment team, I would expect you would get far more than 75 minutes input from home treatment. If you're very poorly and there's a very high risk that you might have to go in hospital, you might be visited by 2 nurses or 2 professional people of any different background, up to perhaps 3, maybe even 4 times a day. If you had a standard CMHT with fairly diligent CPNs, and those CPNs were aware that this particular patient was becoming ill, I'd really like to think that they would spend more than an hour a week with that patient. So it seems ironic that we can actually admit people for greater input, and yet our critics, and a fairly benign piece of research this was too. I mean, it's by no means the most damning study that's ever been done on acute psychiatry, but our critics are saying, well, we find it pretty hard to provide more than an hour's input into patients. This is a view, of course, which has been echoed